I actually developed and copyrighted the SPOT methodology. S for doctor. S, speak to patients and families. P, pacify fears. O, outline what's important to the individual. Not what you think is important to me. Hear what I say is important to me. And T, recognize that the time it may take for somebody to accept a disease, and don't be judgmental if the person don't show up for the first visit.
You're listening to the Health Disparities podcast from Movement is Life. It's being recorded live, in person, and in color at Movement is Life Annual Health Equity Summit. Our theme this year is Health Equity, Solutions from Healthcare Leaders. I'm Conchita Burpee, and I'm on the steering committee one of the steering committee members of the Movement is Life. Additionally, my title in public and professionally, I own my own consulting company, and I am an expert in community-based participatory research, as well as community engagement and marketing. Today, we're going to dive deep on the topic of advancing health equity through respectful, patient-centered communications. I'm joined by two guests today who are going to help us unpack all of this. Dr. Mauvareen Beverley. She is an executive level physician with 20 years experience advocating for improving patient engagement and cultural competency for all populations, especially African Americans. And Dr. Janet Austin is the founder of JSA Chronic Disease Foundation, a national nonprofit aimed at providing resources and support to help people who experience pain due to chronic diseases and helping them to have a better life. Both of you, welcome to the Health Disparities podcast, and thank you for being here, and thank you for your expertise.
Thank you.
Thank you.
Janet.
Yes.
I'll start with you first. I'd like to start and say, can you tell us a bit more about yourself and what set you on the path of becoming an educator, an advocate for people whose lives are complicated by chronic disease and pain?
Well, when I was young and in high school, and around age 16, I was diagnosed with rheumatoid arthritis. And as you know, 16 is kind of the age where they're looking at adult onset rheumatoid arthritis, but because I was at that age, I was often referred to as one with juvenile arthritis. And so as a result, I've had over 50 years now of living with chronic disease pain, comorbidities, and being involved in the medical health centers around the U.S. as I've moved a good bit. So by being involved, I kind of saw some of the things that I wish were different, and some of the things that I really liked about interactions with the clinicians.
Okay. Is this something that was, runs in your family, or how did this disease come about? I mean, how?
They still don't know. They say that just what you said, that it runs in families, but they haven't been able to say that it's in any way a hereditary disease. Yeah,
okay.
Genetic.
All right, well, thank you. Mauvareen, can you please introduce yourself as well and tell us about your journey in medicine with a focus on health equity and improving the health of Black Americans?
Yes, my name is Dr. Mauvareen Beverley, and I think what's important, what led me to where I am today, is being trained, my medical training at Harlem Hospital. I think back then, under the leadership of then Dr. Gerald Thompson, we were not expected to deliver anything except excellent health care to everyone, regardless whether the person was addicted to narcotics or churchgoer. The human value was extremely important, and we were not allowed to make any distinctions between the care that we would deliver based on who or what circumstances that individual had. And I think over the course of time, after I finished training at Harlem Hospital, I went back and worked in community health centers where I grew up in the Bronx. And subsequent to that, got married, and I have my amazing husband and 3 sons. You know, I live in a testosterone-driven household. And now I'm joined the Grandma Club, and I have a grandson.
Oh, congratulations.
So,
That's wonderful.
you. And I think what happened is when I decided to go back to New York City Health and Hospital, I was asked to develop the first care management program. And back then, I think it was around 2008 or so, care management was not a major buzzword. But the person who I reported to, Dr. Ann Sullivan, she was ahead of her time. And so in developing the care management program, it's where I got to understand and speak to over 1,000 patients from all ethnicity, race, and gender, and socioeconomic status. And when I coupled that with my training at Harlem, it resulted in me developing programs and what I refer to as the bridge team. And the bridge team was to bridge the gap, regardless of what the circumstance is, bridge the gap, irrespective of, again, who that individual, what are the circumstances, and which led me to develop what I call a sustainable health equity programs that's still in operational till today.
Well, thank you for that.
Yeah.
Here at Movement is Life Summit, I know that the both of you will be participating in the workshop called Seeing Clinicians Through Patients' Eyes. Many healthcare professionals go to school to learn how to practice medicine or provide clinical care, and they might not know too much about the importance of communication as a central piece of care they provide, as you were just explaining, Dr. Beverley. Janet, can you talk about why communication is so important?
Well, it's not just important, it's critical. To be able to feel comfort with your clinician when you're talking. I, as a patient, oftentimes it's difficult when you first meet your clinician and trying to develop a rapport with them to speak candidly. And so we've learned through a lot of research that in helping to facilitate community where the patient feels they're heard is so important. And what is one of the things in my presentation I wanted to talk about is how, especially in the earlier days, you often left the doctor's appointment without getting the questions you had answered. Or you left and you're in the ladies' room crying because you've had another loss in your life. Yeah. It seemed like every time you went to the doctor, something else was involved and you weren't going to get it back. You know, it was chronic. And it was very difficult as a young person, and then as I grew older. And that brought in the importance of having a strong support system. If you don't have that, it is very, very difficult. You feel lost and alone, and I think that's one of the most important things, and this conference is addressing that we just saw a presentation about having measurable goals. It was called SMART, and it was movement, and having a group that got together regularly, and so you felt like you weren't alone, and you had someone that could talk to that was maybe experiencing the same things that you were.
Right. Mauvareen?
Yes.
What were you hoping to drive home to participants in this discussion this afternoon about respectful and effective communications, which I know that you have. This is your expertise.
Yes, I think it's so important. I think what I would like to drive home is understanding that not just moving the dial from health disparity to health equity, but moving the dial from health disparity to sustainable health equity. So 2 years from now, we're not talking about the same conversation.
Yes.
And I think what I focus on in terms of patient-physician communication is understanding who the individual is. And if we don't start there, then it's going to fail. And I look at it from the perspective of, if your perception of me is not the reality, then my health is going to go south.
That's right.
But if the perception and the reality is the same, good, bad, happy, or sad, then we have an opportunity to collaborate better with patients and families and physicians. And I think one of the focus I focus on is what nobody speaks about in terms of health disparity, negativity in the medical records. And it's been proven that the negativity in the medical records is geared towards particular black patients, particularly black men. And in a book that I've written, 9 Simple Solutions to Achieve Health Equity, a guide for healthcare professionals and patients, one of the simple solutions is the why question. You know, X, Y. What do I mean by that? So if I'm in the hospital or the doctor's office and I was asked, did you take your medication? Or did you follow direction? And I say no. And I've done presentations across the board of different systems. And I've asked the attendees, how many people have heard the word non-compliant? Everybody raised their hands. How many people have heard non-adherent? Everybody raised their hands. But ask, how many times have you heard the associated why question? And maybe of 60 people in the audience, 3 people. So we don't know why John Brown didn't take the medication, but we're going to refill the same prescription that the patient didn't take and then call him non-compliant. And now with the nicer word now, non-adherent, whatever that means. And then recognizing that if those negative language is written in the medical records 2 or 3 times, that patient is under the help bus. Nobody cares about that person then because now it's your fault. And so I look to really encourage health systems, medical schools, nursing schools, social workers, everybody. If you ask the question, ask the patient why. And if you have a moment, I'll give you an example of how the why question saved this man's life. I was at Kings County Hospital, which is a large black population of Caribbean and African American population. The Spanish population was interesting, not from Puerto Rico, Miami, Mexico, they were from Panama. And under colonial rule, the British sent the English-speaking Caribbean to Panama to build the canal, and so they have English and Spanish names, and they look like me. Ronaldo Austin, Antonio Martin, and English was their primary language. The top islands were Jamaica, Trinidad, Haiti, and Guyana, and 95% of the cohorts of African Americans came from the Carolinas. And I'm trying to understand, why is everybody from the Carolinas, you know? Virginia's sort of down the street from us. How come we don't have anybody? And it's after the Emancipation Proclamation, when blacks had their first representation in Congress, their community started to do better than the white communities. They built schools, churches, businesses. Over the course of time, the plantation owner property went south, and nobody was picking the cotton. And over the course of time, the Ku Klux Klan came in and burned the whole place down, and they came up the coastline to New York. And I think these are important to understand, the population that one serves. And so I just want to go, and this population, they don't get asked the why question.
No.
Yeah, so example, 60-year-old African-American male recently diagnosed with congestive heart failure, returns 2 weeks later, heart failure decompensated due to non-compliance. When that person gets admitted to the upstairs in the unit, do you think anybody's going to care about that person? I don't care what hospital across the nation. And my team had to ask why.
Why?
because they said if you don't ask why, they used to call me Dr. B. Dr. B's going to bug out if you don't ask why. I said, why can't you take why didn't you take your medication? I can't take the water pill, which is a diuretic that flushes fluid out the body so the heart could pump better, but it makes you pee a lot. Why can't you take the water pill? And I'm glad everybody's sitting down. He said, because I drive the number 7 train. You know, so when is your shift? 11 p.m. to 11 a.m. What do you do when you get home? I do some chores, I make breakfast, but if I'm going, I take my medication, but if I'm going to my shift, I don't take the water pill. And I brought the same cardiologist in who was ignoring him. And that's why I think I'm optimistic that systems could change
it, right.
Because he told him, okay, take the water pill when you get home, be aware it may wake you up during the day, but by the time you get to your shift, you'll have less of a reason to urinate. But to the degree that you do, we're going to give you a cubicle so you could use in a private space when the train stops.
And that was all because
the why.
Someone asked the question,
why? And you know what the patient said?
What?
If I knew I had to choose between peeing and breathing, I would have chosen breathing. You know.
Yes.
And just the last thing on this point, expand the conversation. Without the why question, you know, he would have been readmitted multiple times. And then there's another negative word, frequent flyer.
Oh.
And so that means you're abusing the system. And if he were to pass, it would be due to noncompliance.
Right. Wow.
And so we saved this elderly black man's life. So he didn't have to choose between his job and his health.
And that was because of why?
The simple why question.
Wow. Janet, what do patients value most when it comes to interactions with their clinicians?
Well, when I worked at the National Institute of Arthritis, Musculoskeletal, and Skin Diseases at NIH, we had an opportunity to bring in representatives from all over the U.S. from different cultures and talk about these types of things. And we learned that with regard to so much care that's being given, oftentimes the patient will actually just feel like the physician knows, so I'll just listen. And so we needed a better way to facilitate that conversation. So they have put in place, in some areas, having someone that translates, someone that also, the information that we have, we make sure that it is not just translated, we learned, but also transadapted, because a patient, we can offend individuals very easily by just running something through a machine, you know, through the computer to translate it.
Right.
It doesn't pick up the different nuances that a straight translation does. And so we really have worked on, when I was there, trying to make sure our literature was available and understood by multicultural communities, as well as underserved areas, because so many don't even have the opportunity to go see, as you know, a doctor, especially in Indian country. Individuals, I know they have their own medical setup, but if they even have a hard time getting to some of the rural areas. And of course in the South and in other areas, the same thing occurs to where they're not able to get in. So I think I think patients very much value feeling that they are being heard and that the physician cares.
Okay, thank you. Maureen, to segue a little bit and to connect the why with why many providers feel like they're pressured to get through the patient's load day of in a productive manner, to listening to them and listening to their day and listening to all of their symptoms and the reasons why they're there. Does a respectful conversation have to be time-consuming to a physician in order for it to be effective?
Yeah. I think from my experience with the heart failure readmission prevention program,
Right.
when Medicare said if you came back in 30 days, we would only pay for one admission, whereas prior to that, they would pay for 2, 4, 6, 8. And so if for no other reason, hospital systems across the nation had to have a system in place for financial reasons, if nothing else, to decrease the readmissions. And what we were experiencing and what we understood and shared with the teams is that first it comes down to heightened human value. Because I know everybody talk about being respectful and this and that, but if you don't value me, you think respect is going to come into your mind or
Right.
your brain? No.
Right.
First is to start with the human value. And so part of the communication was understanding who that individual is. And what I refer to in, some of my conversation is what I refer to as the lookalike syndrome, So what happened was we're seeing a patient, the patient was Indian, and the team said, "Oh, where in India are you from?" And the person he was so upset, "I'm not from India, I'm Guyanese, I'm Caribbean." And it made me to recognize what I call the lookalike syndrome. And I said, go tell a British person they're Irish and see how far you get. Go tell a Chinese they're Japanese.
Right.
Go tell an Indian they're Pakistani.
Right.
Go tell a Ghanaian
true.
that they're
Right.
Nigerian. Go tell a Jamaican that they're Trinidadian. Go tell a Puerto Rican they're from Mexico. And most important, go tell a New Yorker they're from New Jersey. And it's done. And so the reason I bring this up is because we may be from the same geographic location and the
Right.
same space, but if we don't understand the unique cultural differences, then the health outcomes for that individual who
Is
we
not.
lump together may change.
Absolutely.
So it required my team, had to find out who is the individual. Who is the individual?
Who is that
And so
person?
once we found out and we asked the question, so introduce yourself, we would say good morning. So tell me where you're from.
Take the time.
Right. Take the time. So,
But let me just say this about
okay.
the time. And that time was very short. You know why?
Why?
Because at the end of the day, and that's just part of the reason why, we decreased readmission from 30% to 18.7 in just
Wow.
about 2 years. And the teams were excited. Nobody was burnt out. They were happy. They would come in and say, "Oh, Dr. B, can you help us with John Brown?" And it was, we never experienced anything about long wait time conversation, because once they saw the result, I was able to train the staff
Right.
to ask simple questions. So because you need to know who is the individual.
Absolutely.
Don't assume who I am.
That's right.
And so one of the things that I think is important, I did surveys, the same surveys I did the patients is the same surveys I asked the staff, so that to see if we're on the same page.
Right. So,
That's a great
here on the Health Disparity Podcast, we've explored and I've heard concepts of cultural competence or cultural sensitivity. In recent episodes that they've had, I welcome each of your thoughts on what does it mean to provide cultural competent care, especially when it comes to communications, as you just explained.
Yeah.
Janet, part of your workshop here at the summit focuses on understanding challenges of intergenerational communications. Can you give us an example of what it looks like to bridge generational gaps?
Well, I have found, having been diagnosed at 16, that I, as a patient, had to learn a lot as well. But the physician, it is incumbent upon them to be respectful of the individual and to listen and to take the time to maybe learn a little bit about the family, and
Right.
just jot it down in the record.
Just
So
what Mauvareen just talked about, right?
that is just perfect. I was just fascinated listening to her. And I think that we are on the road to these things. If the clinicians in other cultures will take the time to learn and take the time with the patient. Like you said, it might only add another 5 or 10 minutes. Oh, I wanted to say, my internal medicine doctor, I was having a really rough time, I don't know, just a few months ago. And of course, I'm there to talk with her, and I'm crying, and because she's listening and taking. She actually said, Janet, I'm going to go ahead and book you to come back to see me in 3 months. I'm just going to make time for me to listen.
That's right.
And I just, I left so optimistic.
Because someone said that they wanted to listen.
Yes.
Get to know you.
right.
Yes, yes.
So, Mauvareen,
Yeah.
why is patient self-advocacy particularly important? And what can providers do to empower patients to more actively engage in their care?
Okay. So I just want to add to what the
Sure.
conversation about cultural competence.
Yes.
And what you said was so
Important.
so important, and it's we're on the same page.
Yeah.
I mean,
Yeah, I
definitely,
feel it.
Yes.
And I think from cultural competence to me is understanding obviously the patient's culture and to understand what's important in that culture and understanding and putting it into play when you were discussing with the patient. And cultural competence to me has to apply to American-born physicians to foreign-born patients, but also foreign-born physicians to American-born patients, and American-born physicians to American-born patients who are different than themselves. Because if we don't have those three different criteria come together, we will not be able to look at from a cultural perspective. And the notion that patients from other societies, we have to understand that I say you do, as if to say the doctor knows everything and I don't need to say anything. And I think we need to understand the role of culture in different environments and don't assume. And I just give you, and I also want to recognize that the African American elderly population is not a part of the cultural competence conversation. So when a patient said, I picked cotton in the South and I paid my dues, I don't deserve to be treated this way, who understands that? Or went to see a patient in the morning, 9 o'clock, and I said, where are you from? South Carolina. And before I could say, I'm thinking from a medical perspective, are you visiting New York and you got sick, or do you live here? Because the transition of care would be different. And before I could even raise that, she said, my parents were a step away from slavery and my grandparents were slaves. Was I expecting that Monday morning, 9 o'clock?
Oh, my
And I'm going to shorten the story, but I said, tell me about it. And some of them spoke in codes. My family picked cotton on a plantation that was not ours. And then I had to get up at the crack of dawn and pick 300 to 500 pounds of cotton. And that was the same amount of cotton that was in that movie, 12 Years a Slave, really. And then I had to walk 10 miles to a segregated school. I'm saying 10 miles. We can't even go 5 blocks without calling an Uber, And I'm saying, how do you walk 10 miles? And her body language changed and the tone. She said, well, if you want the education, you had to. Like, what part of this don't you get, stupid? And I said, did you have to walk back? She said, no. The principal in the horse-drawn carriage took us back, and we had to get back before dark, before the Ku Klux Klan. I said, how old were you? 10 years old. Could you imagine?
No.
And she went to Voorhees College, it's a 2-year black college in South Carolina. And this is now, she was 80, this is now 60 years later. Guess what her next response was? She was still upset with herself. I didn't get until my second try.
So many people, we all have our life experiences.
Yeah, and I just want to say this. She came to New York, became a dietitian.
Right.
And I said, do you mind me asking, when did you retire? She said, 2000. I said, do you mind me asking you how much you made? She said, $200 a week, but others made more. Read between the lines.
My goodness.
You know,
Wow.
and I think that's so important.
Absolutely.
You know, and I make the reference,
Fascinating.
and you know, I said when a Holocaust survivor comes in the hospital, we roll out the red carpet. The chief medical officer, the board of directors, the CEO, the rabbi will go and see that patient, and so they should, because of the horrific circumstances that they endured.
Exactly.
But when an elderly black person who fled the South because of Ku Klux Klan, lynching, and Jim Crow, how come we don't roll out the red carpet? And it's an opportunity to recognize and treat all atrocity survivors the same, and to recognize the role of religion in these two populations were pivotal to their survival.
Exactly.
You know, and it was a learning curve, you know, and just about that patient, I don't know if you ever heard of Stuyvesant High School, which is it outperforms private and public schools in New York.
Wow.
And her two children were 2 of 5 black children to
that's
integrate
amazing.
Stuyvesant High School.
Wow.
So that's what I'm saying. The cultural competence, we have to include this population.
And that so clearly
Yeah.
illustrates the generational.
Yes.
Yes.
I just,
Yes.
wow,
Yes.
Yeah.
So,
disparities.
is there anything else either one of you would like to add to our discussion today?
You have anything?
Do you have
Yeah,
anything that
Yes,
you wanted to
please
add
go
to
on.
it?
Yeah. I think what I would like to add is that we need to really get an understanding of health systems perception versus the reality. Because if the health systems don't understand what the perception is versus the reality, then the system is going to fail, and they will continue to provide disparate care. And so, like I said, when I do surveys with patients, and I do the same surveys with doctors, you know, like I just said, why don't patients take their medication? And all the doctors said, cost, they can't afford it. This is Brooklyn, you know. Heart failure, taking 5, 6 medication. Okay, sounds like it makes sense, right? What if I told you when I asked the patients, why don't you take your medication? Not one patient mentioned cost. And what was the answer? We don't take our medication because we think we're taking too many medications. Duh.
Interesting.
Duh. So if you're going to design a system based on cost, it's going to fail. So the solution was to bring the pharmacist in. We had an amazing pharmacist on the team who collaborated with the physician. Could we combine the antihypertensive and the diuretics? Does an 82-year-old still need to be on a statin? Does all the anti-inflammatory medications? And so I think that was a major contribution to our results. And the other thing that I would recommend to a system, when you do discharge instructions, and I sat and I listened, and so the nurses say, well, I'm just abbreviating, take the blue ones in the morning, the pink ones in the evening, the yellow. And I said, before you tell the patient what medications to take and when, why don't you ask that person, how do you take your medications? And so maybe when you ask the patient, how do you take your medication, then you could better understand and then provide service. And the last thing I'm going to say is that what's not discussed at all is patient fears. And you demonstrated it in your own medical issues. Patient fears. So you could see how some of this fear could lead to non-compliance.
Absolutely.
And so that's not something that's covered, which is kind of crazy,
Well,
right?
I'm glad you mentioned that.
Well, and the other issue, which I'm sure you could verbalize much better than me, is that as the chronic disease patient gets older and older, especially when they have inflammatory disease, I have 5 specialists now that I have to see. I've had the heart attack, I have diabetes, I have osteoporosis. If you say it, I have it.
Yeah.
And so when you're vulnerable, and you go into a hospital setting and you're faced with all these doctors coming, it is impossible to have clear thoughts, to integrate what this doctor said and what that doctor said. And at one time, my doctor of internal medicine said that she was able to be what she called the quarterback and
Right.
do that. Well, I think doctors are just having so much demands on their time that to be able to do all that unless you make an appointment is difficult. Unless you actually bring it to their attention and ask. So that's where I think that to have a family member to go to
Present.
the appointments
Yes,
with you if at all
absolutely.
possible, and to get a notebook
Yes,
and
take
start
notes.
putting stuff in it, because and document every call that you make to the doctor's office. Just write a little note.
I totally agree.
All of that is just so important as as you move through your lifespan.
Right.
Yes.
Right.
And then when you get to the older,
Yes.
what can we remove?
Yes.
That's what my mother said.
yes.
I want one pill.
Yes.
I don't know that we can get there, Mom, but we work toward it.
It's interesting you talked about fear. We talked about fear for a minute. I always didn't understand why when I went to the doctor, my pressure would go up. Normally my pressure doesn't go up, but I had white coat syndrome.
Right.
I had the fear of, I don't know whether it was seeing a physician or what they were going to tell me that I had or didn't have, but I always got white coat syndrome. And I believe you're absolutely right, Mauvareen. There are very little discussions about fear when it comes to the medical industry.
Yeah.
But before I, I'm sorry, did you want to add something?
No, just an example, if you have time, for the fear factor and how it came in. And this is what I'm talking about in my book. These stop in my tracks moments that led to boots on the ground, simple solution. So there was a patient, dialysis patient, and for every time he goes to the doctor, ambulatory care, the doctor writes, patient refused dialysis, refused dialysis, refused dialysis. And so he was finally admitted, and his kidney functions were worsening. And I said, did anybody talk to his wife? Does his wife come to visit? She comes every evening at 5 after work. So I waited to speak with her, and I said to her, I know you love your husband, but if you don't convince him to accept dialysis, he may not be here with you much longer. And she said, I don't think I want to do that. And I'm saying, what? And I had to compose myself. And again, practice what you preach. Tell me why. And she said another powerful statement. I don't think I could live with myself. That's a powerful statement.
Wow.
Why? She said, because our neighbor down the hall from us went on dialysis, and 2 weeks later he died.
Oh,
So how much of
Yes.
us would be rushing to put family
Right.
members?
Right.
But if you just, and the same, that's why, again, I think there's change can be done in system. So I brought it to the attention of the nephrologist, and I said, you're gonna have to, they need hand-holding. And he met with them, and I was there. He said, I don't know why your neighbor passed. Could have had a stroke, could have had a heart attack, could have, kidneys could have failed. But one thing I will tell you, if you agree to dialysis, I will be there with you for the first week.
Oh, that's good.
How many nephrologists, go to
Gonna
dialysis?
take that personal.
That's
And
wonderful.
again, it's when I realized the fear factor. And I think one of the things I actually developed and copyrighted the SPOT methodology. S for doctor, S, speak to patients and families. P, pacify fears. O, outline what's important to the individual. Not what you think is important to me. Hear what I say is important to me. And T, recognize that the time it may take for somebody to accept a disease, and don't be judgmental if the person don't show up for the first visit, and so that's the SPOT methodology.
I'd like to thank my guests, Dr. Mauvareen Beverley and Dr. Janet Austin, for being with us today. I've really learned a lot of information from these talks, and thank you so very much for sharing. You can find these links to more information about the work that our guests do at the links of our next show meeting. That brings us to the end of another episode of Health Disparity Podcast from Movement is Life. I'm Conchita Burpee. Until next time, be safe, be well. Thank you so very much.